teaching us on constriction versus restrictive physiology. So this is one of the most commonly asked topics in the exam, and one of the most difficult topics also that we often fail to understand. On this journey, we also have Professor Ankit Bansal, who is Associate Professor of Cardiology from GB Pant Hospital, and we have the pleasure of having Dr. Sanjeev Sharma, who is cardiologist at the Batra Hospital. So let us listen to the one of the most avid teachers, Professor Dayasagar Rao, who is a senior consultant cardiologist in the Krishna Institute of Medical Sciences, Hyderabad. He's one of the most sought after speakers, and welcome, sir, to, and thank you so much for agreeing to be on this particular webinar. Thank you so much on behalf of all the residents. Now over to you, sir, please. If you have any questions, my dear friends, please post on the chat, and we will definitely ask all the questions in the end.
My slides are not visible now because it was there.
You can share your screen.
Yeah, share the screen, but anyway, I'll just again download it and then see it. Yeah, okay. Okay. Good afternoon, everybody. Good evening to everybody. It is indeed a pleasure and then a privilege to be giving a talk to all the people who are interested in clinical cardiology and mostly diagnostic process here. Unlike many of the webinars wherein we see a lot of talk about interventions, this is basically a clinical cardiology session. I've been requested to speak on a differentiation of constrictive pericarditis from a restrictive cardiomyopathy, which it very closely simulates. So now, what is common to both of them, restrictive cardiomyopathy and constrictive pericarditis, is they often present as right heart failure with elevated JVP, edema of the feet, and sometimes ascites preceding the edema of feet, what we call ascites precox. This is a classical symptom of what we call constrictive pericarditis, but it can happen with any of the predominant right heart failures. And from the physical science point of view, both of them share something like a very quiet pericardium. There may be mild cardiomegaly, and the pericardium is quiet, maybe some outflow pulsations, both in terms of constrictive pericarditis, where the pulsations is mostly diastolic. And apex beat in constrictive pericarditis is classically taught as non-palpable, non-localizable, which may not be the case with the restrictive cardiomyopathy, especially in the later stages of the disease when the systolic dysfunction becomes more manifest. And important physical sign is, by and large, in constrictive pericarditis, there are no audible cardiac murmurs. Mark the word audible cardiac murmurs. This is totally different from what you get on the echocardiogram, wherein they say there may be mild MR, mild TR, all kinds of things. But from the clinical point of view, in constrictive pericarditis, classically, there are no audible murmurs. There may be additional sounds in diastole by way of a pericardial knock, which might be mistaken for a third heart sound. And in patients, fourth heart sound is extremely rare, is almost unknown in patients with constrictive pericarditis. Whereas in patients with restrictive cardiomyopathy, especially when they are in sinus rhythm, a palpable fourth heart sound is not uncommon. So it is important to realize that constrictive pericarditis as an entity is not a single entity. Those were the days in the past wherein we used to have constrictive pericarditis due to a consequence of tuberculous pericarditis followed by constrictive pericarditis. The present day scenario is more often than not, a constrictive pericarditis is associated with sometimes what we call myocardial diseases, sometimes associated with post-cardiac surgery, all kinds of things. So, but common to all this, what we call complex constrictive pericarditis, is the pericardium is thickened, fibrosed, and very tense. And since the pericardium is generalized disease here, there is constriction that is generalized, both affecting both the right side of the heart as well as the left side of the heart. Although occasionally there may be a localized constriction around the AV groove, but that's a bit uncommon. But sometimes we do get it, a constriction that is specifically localized to the AV groove, sometimes over the pulmonary artery. That might give you some idea about there may be occasional short systolic murmurs in these patients. But by and large, constrictive pericarditis is characterized by absence of any audible cardiac murmurs. Especially in some of the patients with constrictive pericarditis, especially secondary to radiation, mediastinal radiation because of lymphomas or some other malignancies, this radiation not only causes pericardial fibrosis, it also causes both myocardial problems, it also causes endocardial problems, it also affects the walls. So such complex constrictive pericarditis is difficult to diagnose, but I'll tell you how to go about it in making the diagnosis. Now, in the last one decade or so, a post-surgical constrictive pericarditis following CABGs have been well documented. Although its frequency is less, probably about 1% at the maximum, and the usual time interval between CABG and the onset of constriction clinically is approximately about 2 years and beyond. So the clinical presentation of these patients with constrictive pericarditis is influenced basically by what we call associated myocardial problems, associated valvular problems. But in a so-called isolated, severe symptomatic constrictive pericarditis, pericardium is quiet and no murmurs. It is important to remember that when we talk about restrictive cardiomyopathy, we often refer to idiopathic type of restrictive cardiomyopathy, more often in children and the adolescents and adults, basically a genetically predisposed disease. But not to forget that there are other forms of cardiomyopathy that can present as restrictive cardiomyopathy, which I have outlined here, like inflammatory diseases like endomyocardial fibrosis, lifeless disease, post-radiation also it can happen, including restrictive myocardial problem, infiltrative diseases like amyloidosis, storage disorders like glycogen storage disorder, Fabry's disease, and hemochromatosis. Common to all these things is there's a diastolic dysfunction. There is restriction to the filling of the ventricles. The systolic function of the ventricles is by and large is well preserved, at least in the initial stages of the disease. But as the disease progresses, like all cardiomyopathies, that the systolic dysfunction also becomes worse. So what are the major pathophysiological differences between the pericardial diseases and myocardial diseases? It is important to remember that in a classical constrictive pericarditis, it is only the pericardium that is thick and generalized, and it is very fibrous, and it has got a restricted space in which both ventricles have to fill, one after the other sequentially in both phases of respiration. In contrast, in restrictive cardiomyopathies, the pericardium is normal, but the myocardium is very stiff due to various pathological conditions, which I've already alluded to. So, whereas the constriction, the impedance to ventricular filling is after the first 1/3 of diastole, practically there is no filling of the ventricles, both on the right side as well as on the left side. Whereas in restrictive cardiomyopathy, that the filling abnormality is present throughout the diastole. And because the pericardium is thickened, there is going to be some problems in terms of the negative intrathoracic pressure is not transmitted to the intrapericardial structures. I will just highlight in the next succeeding slides. So this is basically the major differences. For you to understand the hemodynamics of constrictive pericarditis, it is very important that you understand the normal pericardium, its extent of coverage, and its role in normal and its role in abnormally thickened pericardium. It is a two-layered structure consisting of a visceral pericardium and parietal pericardium. When we talk about constrictive pericarditis, it is worthwhile remembering that the constriction not only occurs in the parietal pericardium, but also of the visceral pericardium. And the surgeon has to be careful in not leaving the visceral pericardium. If the surgeon does not remove the constricting visceral pericardium over the epicardium or the ventricles, then although he might have removed the parietal layer, that the functional consequences of constrictive pericarditis will not be relieved and the patient continues to be symptomatic. And it is worthwhile remembering that one of the causes of persistent symptoms and persistent functional abnormalities is probably because of a residual constriction, because visceral pericardium has not been removed. And it is worth remembering that the normal pericardial thickness is approximately about 1.5 to 2 millimeters in thickness by any of the imaging methods of what we have. So it is important to remember that although the right atrium, right ventricle, left ventricle are completely intrapericardial, the left atrium is not completely intrapericardial. And this is one of the important things to understand why the respiratory changes do occur in patients with constrictive pericarditis. If all the what you call chambers, that is right atrium, right ventricle, and left atrium also intrapericardial, things would have been totally different. Suffice it for you to remember that left atrium is not completely intrapericardial. One of the easiest way of remembering that is when you see a patient with severe, what you call massive pericardial effusion, you rarely see the effusion behind the left atrium because there is no pericardium there. So it is worth remembering that left atrium, at least partially, is extrapericardial. Just want to remind you that the intrapericardial pressure is something similar to intrapleural pressure, which is subatmospheric. It is compared to the atmospheric pressure, it is less by about -2 to -5 millimeters of mercury, depending upon the phase of respiration. The concept of transmural pressure has to be understood to see the impact of the pericardial diseases on the hemodynamics. When we say transmural pressure, the pressure across the ventricular walls, across the atrial walls. When we say transmural pressure, we mean intracavitary pressure minus intrapericardial pressure. In this patient, normal person, the intracavitary pressure on the right atrium is about 5 millimeters of mercury, and the intrapericardial pressure is -2 millimeters of mercury. So the total transmural pressure will be 5 plus 2, that will be 7 millimeters of mercury. So it is this transmural pressure that really causes the stretching of the ventricular myocardium that really influences the amount of blood that is ejected out as the stroke volume. Now this next slide is very important to understand, and what happens to the right-sided pressures and left-sided pressures when you breathe normally. When you inspire, the intrathoracic pressure decreases, so it becomes more negative. So when you have got a more negative pressure intrathoracic, more blood is sucked into the right side of the heart. So the flow to the right side of the heart increases. But remember, even though the flow increases to the right side of the heart, the right atrial pressure and right ventricular diastolic pressure continue to fall. This fall in the pressure on the right side at a time when the flow is increasing is because the negative intrathoracic pressure is transmitted to the intrapericardial structures, that is right atrium and right ventricle. During the inspiration, since the lungs expand, a lot of blood is held back in the pulmonary circulation, and there will be less return to the left side of the heart, to the left atrium and to the left ventricle. So even on the left side, there is a decrease in the pressure, both in LA as well as LV. So During inspiration, there is decrease in the right-sided pressures, and there is also decrease in the left-sided pressures. So this is what we call concordant pattern. That means both are moving in the same direction. Opposite thing happen during expiration. Now, if you see it here, when you inspire, the right heart dynamics, we have already told you that in spite of increase in the flow, there will be fall in the pressure because of negative intrathoracic pressure is transmitted to intrapericardial structures. Left heart dynamics is during inspiration, there's a decrease in the venous return to the left atrium and consequently the left ventricle. So the LV stroke volume falls. Consequently, systolic blood pressure during inspiration also falls. This fall in the systolic blood pressure during inspiration is around 2 to 5 millimeters of mercury, assuming that the patient does not have any respiratory distress. So this is what we call an exaggeration of this fall in systolic blood pressure is what we are calling as. So the pulse pressure also falls and the ventricular ejection time is also decreased. The ventricular ejection time decreases because there is less amount of blood to be ejected out. And the QA2 interval also decreases. And the mitral E wave velocity also decreases normally. But this amount of decrease in mitral E wave velocity is approximately about 10%. All these things go in the reverse direction during expiration. So now what happens in constrictive pericarditis? It is worth remembering that pericardium is chronically inflamed, leading to thickening of the pericardium and tethering of the pericardium to the underlying epicardium. It is this tethering of the pericardium to the underlying epicardium that has got some diagnostic features when we come back to the diagnosis of constrictive pericarditis. And in about 1/3 of the patients with constrictive pericarditis, there may be calcification of the thickened pericardium. Not only there is anatomical abnormalities of the pericardium, this thickened pericardium decreases the elasticity, so it cannot expand anymore. So it becomes a rigid shell, and that is going to limit the space available for the ventricles to expand. So because of the intrapericardial space is decreased, one ventricle has to fill at the expense of the other ventricle, what we call exaggerated ventricular interaction. So when the right ventricle is filling during inspiration, the left ventricle will becomes less filling. So there is a competition between the right ventricle and left ventricle at any phase of the respiration. So this ventricular interaction is very much exaggerated in patients with constrictive pericarditis. And this is not present in restrictive cardiomyopathy. This is an important thing to remember when we come to the diagnostic procedures and the differential diagnosis between the two. So if thickening of the pericardium is one of the pathological features, why not we differentiate them just by knowing the thickness of the pericardium? If the pericardium is thick, then probably if the pericardium is thick and then there is right heart failure, we only have to think in terms of probably 99% possibility of having a constrictive pericarditis. But remember, the way to measure the thickness of the pericardium is not by echo. At least transthoracic echo is not reliable in terms of measurement of the thickness of the pericardium. There's one study done from the Mayo Clinic wherein they have shown that transesophageal echo measurement of the thickness of the pericardium almost nearly corresponds to the thickness of the pericardium measured by CT in that particular study. Not only we can study the thickness of the pericardium by CT, but we can also do it by MRI. Probably MRI in the differential diagnosis of these diseases is underutilized, at least in Hyderabad. So chest imaging probably is by way of a 2D echo is probably one of the methods, and then see what is happening to the morphological abnormalities that occur in these two conditions, that is constrictive pericarditis and restrictive cardiomyopathy. This is a diagrammatic way of showing that. You will see that that blue line that is covering the outer area of this image is the pericardium, and the image C, where the blue line is very thick, is the constrictive pericarditis. Remember that both restrictive cardiomyopathy and constrictive pericarditis, the ventricles are less than normal size or normal size, but the atria are disproportionately enlarged. More so in restrictive cardiomyopathy, less so in constrictive pericarditis. It is equally important to remember that the AV walls are normal and the thickness of the cardiac muscle, at least in constrictive pericarditis, is almost always normal. And in patients with restrictive cardiomyopathy, especially in the secondary forms like amyloidosis, there may be hypertrophy of the ventricular wall in thickness. Whereas in comparison to that, normally the ventricles are much bigger than the atrium in an otherwise normal heart, and the pericardium is thin. So common to both restrictive cardiomyopathy and constrictive pericarditis is normal ventricular size, markedly dilated atria involving both right atrium as well as left atrium. Now, the second common thing between the two, constrictive pericarditis and the restrictive cardiomyopathy, is what we call restrictive flow pattern across the AV walls, both across the tricuspid wall and across the mitral wall. What we are aware of it is what we call restrictive pattern of mitral blood flow. Is the E by A ratio is usually between 1.5 to twice the normal value, twice the control values. Normally, E by A ratio is something like 0.8 to 1.2. That means E wave and A wave are almost equal, plus or minus 20%. So generally, E is taller than the A wave. But in patients with restrictive physiology, which includes both restrictive cardiomyopathy and constrictive pericarditis, the pattern of the mitral flow is what we call restrictive pattern, where the E by A ratio is higher than 1.5, and E wave deceleration time, which is the time taken from the peak of the E wave to the end of the E wave extrapolated to the baseline. E wave deceleration time is also shorter, generally around 130, 140, but less than 160. And isometric volumic relaxation time is also small, less. Normally it is less than 60 milliseconds. But this type of pattern of flow is common to both constrictive pericarditis and restrictive cardiomyopathy. So once you see 2D echo image of ventricle size being normal in size or smaller in size, and both atria are dilated, and if you see the mitral flow pattern, that is blood flow pattern across the mitral wall, which shows a restrictive pattern, then probably you need to think, is it constrictive pericarditis or is it a restrictive cardiomyopathy? If the ventricular muscle is thick, probably it is more likely to be a restrictive cardiomyopathy. If the ventricular wall is normal in size, it can still be restrictive cardiomyopathy, or it can be constrictive pericarditis. So 2D echo has got some important information. And if we can see that by and large, you can see the pericardium is thickened and glistening, and it is hyperechoic, because if it is calcified especially, you do get what we call calcification pattern of the pericardium. Can the electrocardiogram help in the differential diagnosis of constrictive pericarditis from the restrictive cardiomyopathy? Maybe, but generally ECG is non-contributory. In both conditions, the rhythm is sinus. Although in elderly patients with constrictive pericarditis, 25 to 30% of them can be in atrial fibrillation. The presence of atrial fibrillation in these patients makes the diagnostic procedures very difficult, and probably that is one of the most difficult cases to diagnose or to differentiate between restrictive cardiomyopathy and constrictive pericarditis who are in atrial fibrillation. Probably it is in those patients that we have to resort to invasive procedures like cardiac catheterization, including right heart and left heart catheterization. Otherwise, ECG is probably non-contributory. By and large, in constrictive pericarditis, it is in sinus rhythm, except in the elderly where they can be in atrial fibrillation. No chamber enlargement. QRS axis is normal. No chamber enlargement. No conduction disturbances. And voltage is generally on the lower side. No LVH, no RVH pattern. LVH, on the contrary, voltage can be low. And there is a generalized T wave inversion. If all these signs are present, more likely to be a constrictive pericarditis. But then you cannot bet on it, only on the electrocardiogram. So this is one of the classical ECGs wherein you can see that normal, non-specific, no low voltage, but generalized T wave changes are also not there. But this is the usual type of electrocardiogram that is available to you in this differential diagnosis. Does chest X-ray contribute to the differentiation between constriction and the restriction? The answer is probably yes, provided the pericardium is calcified. And that calcification is present anywhere between 30 to 50% of the patients, depending upon the duration of constrictive pericarditis before the diagnosis is made. This is one of the X-rays which shows the calcification. For identifying the calcification of the pericardium, the best view of a chest X-ray is left lateral view, wherein you can see the calcified pericardium extending anteriorly over the apex and into the diaphragmatic surface. But this kind of a classical pattern of calcification, although it is very typical for constrictive pericarditis, is very unusual. Second thing is, calcification of the pericardium is not synonymous with constriction. This is an anatomical diagnosis. Calcification of the pericardium is an anatomical diagnosis. You need to show that this calcified pericardium has got its functional effects in interfering with the filling of one ventricle or the other. We'll come to that a bit later. Now, are there any other investigative modalities, advanced investigative or advanced imaging methods? Probably MRI is underutilized. MRI is not only useful for identifying the pericardial thickness, but it can also identify whether pericardium is actively inflamed or not inflamed. If it is actively inflamed, certainly it makes the diagnosis a bit easier. Equally importantly is the late gadolinium enhancement of the myocardium. If there is late gadolinium enhancement of the myocardium, that means there is myocardial fibrosis, and it is unlikely to be an isolated constrictive pericarditis. More likely to be a cardiomyopathy rather than a pericardial problems. We'll show you some of the pictures. Now, this is another way. CT is very good, especially in identifying the thickness, but more importantly, the calcification of the pericardium is best made out by CT. So in MRI, you can see MRI can also identify the alteration in the shape of the ventricles. This is not common, but when it is present, it is highly specific. You can see that a thickened pericardium shaded in the dark black and also in shaded lines. But the cavity of right ventricle and left ventricle may get distorted. More often than not, it is the right ventricle that gets distorted. This distortion of the cavity of the right ventricle does not occur frequently. So its sensitivity is low. You can see here, sensitivity is only 34%. But if it is present, it is very highly specific for constrictive pericarditis. Specificity is almost 100%. So when you're really looking at the MRI, cardiac MRI with gadolinium administration, then if the cavity of the right ventricle is distorted, does not look normal, and there is up and down of the anterior surface of the right ventricle with obliteration of the cavity of the right ventricle, that's going to be more likely to be a constrictive pericarditis rather than a restrictive cardiomyopathy. Now, this is one of the things where we have done the gadolinium enhancement. You can see that in the top right-hand corner that is labeled as C, that late gadolinium enhancement shows that brightness in the endocardial region. And this is a case of a cardiac amyloidosis, simulating as the constrictive pericarditis or restrictive cardiomyopathy. So MRI probably is now going to become one-stop shop for the differentiation between constrictive pericarditis and restrictive cardiomyopathy. So far, we said that the pericardium and myocardium structural evaluations. One of the studies coming from Mayo Clinic has shown that you can have severe, significant symptomatic constrictive pericarditis with no thickening of the pericardium, either by CT and even by histopathology. Although histopathologically it was abnormal, that the thickness of the pericardium was not increased. So the absence of pericardial thickening does not rule out a constrictive pericarditis, just as the presence of thickened pericardium is not synonymous, although it does favor the constrictive pericarditis. But remember, in these patients, almost about 1/3 of the patients, 28% of the patients, had a normal CT scan pericardial thickness. So the absence of pericardial thickening does not rule out a constrictive pericarditis. Is there any blood test by which we say that we can differentiate easily between constrictive pericarditis and restrictive cardiomyopathy? The answer is probably yes, but there are a lot of lacunae. In one of the studies, actually, that the difference between constrictive pericarditis and restrictive cardiomyopathy is the wall stress in cardiomyopathy is increased. Since the wall stress is increased, there is increased secretion of the NT-proBNP and BNP. Whereas in case of constrictive pericarditis, there is no increase in the wall stress. Although the end diastolic pressures are elevated, there is no increase in stretch on the myocardium, unlike in cardiomyopathy, wherein there is an increase in stretch on the myocardium. This increase in stretch on the myocardium that causes release of BNP, which is not the case in pericarditis. So if you find that the patient suspected to be constrictive pericarditis, and then you find that the BNP is normal, probably you're right. But then the BNP is elevated, it is not synonymous with what we call restrictive cardiomyopathy. This is one study wherein if the patient has got associated chronic kidney disease, which nowadays is increasing in frequency, a constrictive pericarditis with associated chronic kidney disease, that the levels may be increased, even though there is no myocardial problem. Because as you are aware, in patient with CKD, there is elevation of the NT-proBNP, even in the absence of any myocardial problems. So it is compounded by the fact that associated diseases in the setting of constrictive pericarditis might make the diagnosis a bit difficult. But in the absence of that, patient with right heart failure, normal BNP values, and no murmurs on auscultation, and then if the BNP values are normal, probably more likely that you are dealing with constrictive pericarditis. Now, one of the important things, important diagnostic features between constrictive pericarditis and the restrictive cardiomyopathy is that the thickened pericardium resulting in constriction has got two adverse effects hemodynamically. One is there is failure of the transmission of the negative intrathoracic pressure to the intrapericardial structures, what we call dissociation of intrathoracic pressures from the intrapericardial pressures. Second functional abnormality or the hemodynamic abnormality is the exaggerated ventricular interaction, by which I mean one ventricle is filling at the expense of the other ventricle because of limited space available in the pericardial sac because of thickened pericardium. This forms the basis of differentiation between restrictive cardiomyopathy and constrictive pericarditis. In contrast, in case of restrictive cardiomyopathy, the pericardium is normal in thickness. It does transmit the negative intrathoracic pressure to the pericardial structures. So this forms the basis of differentiation using a echo Doppler. Now, one of the things what we have seen here is normally when you inspire, if you are doing a right heart catheterization or the right atrial pressure, or for that matter, clinically at the bedside, you will find that during inspiration, the jugular venous pressure falls. Failure of the jugular venous pressure to fall is abnormal. We are going to call it as a Kussmaul sign. So this can be documented even by right heart cath. But at the bedside, it may be sometimes difficult, but you can confirm it here. Normally, when you inspire, the right atrial mean pressure falls, and consequently, the jugular venous pressure falls. This is basically because the transmission of negative intrathoracic pressure to the intrapericardial structures, that is right atrium. But in constrictive pericarditis, it is not transmitted. So increasing venous return results in increase in pressure, not a fall in the pressure. So this is an important physical sign, hemodynamically documented. The second abnormality, what you find in the jugular venous pressure, is that in patients with constrictive pericarditis, you do find exaggerated X descent as well as Y descent. Mostly the Y descent is very prominent, and this rapid Y descent is called a Frederick sign. This Y descent being rapid indicates that the venous pressure is normal and there is a free communication between right atrium and right ventricle. This rules out any tricuspid valve disease simulating a constrictive pericarditis. Okay, so rapid Y descent and then a steep X descent, both are common. In contrast, in restrictive cardiomyopathy, the Y descent is sharp, but the X descent is more often than not, it is blunted. Part of the reason why the X descent is blunted in restrictive cardiomyopathy is there is not only ventricular myopathy involving a ventricular muscle, there is also atrial myopathy involving the atrial muscle that fails to relax during the atrial diastole. It is this failure of the atrial relaxation that causes blunting of the X descent. That is the second reason why the X descent is shallow in patients with restrictive cardiomyopathy is quite often they are associated with tricuspid regurgitation. In the setting of tricuspid regurgitation, the X descent becomes less steep and almost disappears if it is very severe, resulting in a positive wave instead of a negative X descent. So there are two reasons why X descent is what we call blunted in patients with restrictive cardiomyopathy because of the atrial myopathy causing failure of relaxation of the atrium. Second thing is associated tricuspid regurgitation that blunts the X descent. In contrast, in constrictive pericarditis, there is prominent X descent as well as prominent Y descent. Now, this point is probably will come back that being enclosed in a thick, rigid, calcified pericardium, all the pressures in diastole are almost equal. Right ventricle, right atrial mean pressure is equivalent to right ventricular end diastolic pressure, equivalent to left ventricular end diastolic pressure, equivalent to LA mean pressure. So this equalizations of pressures in diastole between the right side and left side, between the atria and ventricles, is almost synonymous with constrictive pericarditis. We'll tell you that this kind of situation also can occur in restrictive cardiomyopathy when it is involving both not only the right ventricle but also the left ventricle. Now, the second important thing in case of invasive investigation is the method of filling of the ventricle in early diastole. In case of constrictive pericarditis, there is abrupt relaxation. There is what you call most of the filling occurs within the first 1/3 of diastole, and subsequently there is no filling at all because there is rapid rise in the end diastolic pressure, with rapid rise of the diastolic pressure. So it becomes like a what we call a square root sign. That means almost all the filling occurring within the first 1/3 of diastole and no filling in the rest of the 2/3 of the diastole. This is very typical of constrictive pericarditis. This sort of thing is seen not only in the left ventricle but also in the right ventricle. And this sort of thing is a bit less likely in restrictive cardiomyopathy, but it does occur. Remember, it does occur in patients with what we call restrictive cardiomyopathy. So if you take the traditional hemodynamic criteria for the diagnosis of constrictive pericarditis, we say LV EDP equivalent to right ventricle end diastolic pressure. When we say almost equivalent, that means almost within 5 millimeters of each other. We say it is almost equivalent. That is in favor of a constrictive pericarditis. If they are differing by more than 5 millimeters, that means they're unlikely to be a constriction, more likely to be a restrictive cardiomyopathy. Pulmonary hypertension is very unusual in constrictive pericarditis, and it is not uncommon in patients with restrictive cardiomyopathy, especially when it is involving the left ventricle as well. So, absence of pulmonary hypertension, equalizations of the pressures in both sides of the heart, right ventricle and left ventricle within 5 millimeters of each other used to be the classical criteria. But then if we analyze the data here, this is a study wherein we try to analyze the traditional hemodynamic data, comparing constriction versus restriction in all the parameters, diastolic pressures, RV systolic pressures, the ratio of the RV end diastolic pressure to the RV peak systolic pressure. There is a lot of overlap. So we had a lot of difficulties. What we thought was constrictive pericarditis, you do a thoracotomy and then say, surgeon says that this pericardium is very thin, so it is unlikely to be a constrictive pericarditis. So we used to make a lot of errors based on this. So then came this invasive investigation of respiratory response to right ventricle and left ventricle. This is important to understand. As I said, there is dissociation of intrathoracic pressure from the intrapericardial pressure. So this results in what we call a discordant pattern between the RV and the LV during both phases of respiration. For example, in this diagram, you will see that during inspiration, that the second complex here shows there is a marked increase in the RV pressure, systolic pressure, but there is a decrease in the LV pressure. So this is what we call a discordant pattern of ventricular pressures with respect to the respiratory phase. Whereas the opposite occurs in expiration, wherein the left ventricular pressure goes up, whereas the right ventricular pressure goes down. So this discordant response of the ventricular pressures in response to respiration is very classical and almost diagnostic of constrictive pericarditis, and it rules out restrictive cardiomyopathy. This is an important thing. So if you have to choose an invasive parameter for diagnosis of constrictive pericarditis, invasive parameter, then probably I'm going to choose the simultaneous measurement of RV and LV pressure and its response to respiration. Now, having said this, sometimes it's very difficult to find out this kind of a thing in patients who are in atrial fibrillation. Now, this has been quantified, that the degree of change has been quantified by calling it as a systolic area index, wherein the RV area expressed as a percentage of LV area during inspiration, divided by RV area as a percentage of LV area in expiration. If both are moving in the same direction, this will be something like a 1 only. But if both are moving in a different direction, that's what we call discordant pattern, this will be more than 1. So anything, if this ratio is more than 1.1, that means more than 10% change, then it is in favor of a constrictive pericarditis, and it is against the diagnosis of a restrictive cardiomyopathy. Now, and this is basically because, as I said, this is a manifestation of exaggerated ventricular interaction. You see in the diagram in this slide, that pictorial diagram, that during inspiration, the RV is filling and then it is pushing the interventricular septum towards the left ventricular side. And during expiration, the reverse is happening. It is for this reason that during inspiration, the right ventricular pressure increases and the left ventricular pressure falls because the septum is moved towards the left side, causing less filling to the left ventricle. So it is this discordant pattern of the pressures in response to respiration is the classical hallmark of constrictive pericarditis, and it does not occur in patients with restrictive cardiomyopathy. Now, if you take all the signs here, if you see all the hemodynamic evaluations by invasive methods, what we call catheterization data, if you see the last one, systolic area index more than 1.1, the sensitivity is 97%, specificity is 100%, positive predictive accuracy is 100%, negative predictive accuracy is 95%. When we say negative predictive accuracy that means if there is no discordant pattern, you can rule out constrictive pericarditis. So you really need to look at the what we call the response of the systolic or the RV pressures and LV pressures in response to inspiration and expiration. Whereas the other one, for example, equalizations of the pressure, sensitivity was only 46%, positive predictive value was only 58%. All the other things, including even the inspiratory decrease in RA mean pressure less than 5 millimeters of mercury, was only, specificity was only 37%, sensitivity was 71%. That means in 30% of the people, there was a decrease in the inspiratory RA mean pressure, even though the patient has got a constrictive pericarditis. So coming back to the most important and most sensitive and specific criteria for diagnosis of constrictive pericarditis by catheterization is the systolic area index, which has got a very high sensitivity, specificity, positive predictive value, and negative predictive value. But then, do we need to do cardiac catheterization in 2020 to make a diagnosis of constrictive pericarditis? The answer is no. Even in Mayo Clinic, they say that this is catheterization is used for diagnosis only in difficult patients, and in their series, it does not exceed more than 30% of the total number of patients come for investigation of constrictive pericarditis. So in 75 to 80% of the patients, the diagnosis can be made very confidently using echocardiographic criteria. This exaggerated ventricular interaction can also be shown not only by the hemodynamic investigations, but also even by M-mode echo. You can see here that during inspiration, because the RV is filling, you can see the interventricular septum moving towards the LV and increasing the size of the RVOT and decreasing the cavity of the LV cavity. So this is a sign of an exaggerated ventricular interaction. So this is the what we call echocardiographic equivalent of the discordant movement or discordant pressure pattern, what you get it in the cath lab. So this is a simpler way if you can show it. But then you need to have a respirometer. Usually what we apply is a nasal respirometer. And during inspiration, the RV cavity size is increasing at the expense of the LV cavity. And the reverse happens in expiration. You can see it there within the last one, where the RV cavity is becoming less and LV cavity is becoming more. And this is basically because the interventricular septum is very compliant and it is moving from one direction to the other. It is this, what you call respiratory movement of the interventricular septum, facilitating filling of one ventricle at the expense of the other, is almost a classical hallmark. This is the equivalent, this is the echocardiographic equivalent of ventricular discordance, what you find on the cardiac cath. So if you find it on the M-mode echo, this kind of a pattern, you don't have to do a cardiac cath. But then again, as I said, in cases of atrial fibrillation, this is difficult to interpret because of changing cycle lengths, and that might influence your cavity size. Now, the other patterns are very much familiar to you, that the respiratory variation of the E wave velocity of the mitral flow pattern. If there's a decrease in the E wave velocity by 25% or more during inspiration, that is supposed to be what we call a respiratory variation. And this is something like what we call a dissociation of uh, intrathoracic pressure from the intrapericardial pressure. That is the reason why is normally also there is a decrease in the E wave peak velocity during inspiration, but that decrease is only 10%. That only shows that the flow to the left side of the heart during inspiration is also less under normal circumstances, but is much less during inspiration in constrictive pericarditis because of the what you call ventricular interdependence. Right ventricle has got no space, so it is encroaching onto the left space, and then it causes marked decrease in the left ventricular input, and that causes this marked decrease in the variability of the amplitude of the E wave Doppler. So this, if it is present, probably it is consistent with constrictive pericarditis. In restrictive cardiomyopathy, this does not happen. So the respiratory variation of the mitral inflow does not happen. So if the respiratory variation of the flow Doppler is not present, more likely to be a restriction. If the respiratory flow of the mitral inflow is exaggerated, that is from 10% it goes to 25 to 30%, is more likely to be a constrictive pericarditis. Now, the same way, that is the left-sided flow, this is the right-sided flow, is hepatic venous Doppler. Normally, you remember that the hepatic venous flow is, most of the flow occurs during ventricular systole and less flow occurs during ventricular diastole. Easier way to remember this flow pattern is, remember that X descent is more negative than the Y descent under normal circumstances. So what happens in constrictive pericarditis is there is a reversal of the flow in the late diastole. Normally this reversal of the flow is very less, but this reversal of flow mostly in expiration, if it is more than 25% of the forward flow velocity, is almost diagnostic. But again, I want to emphasize here that unless you have respirometer, it is difficult to interpret this data. So hepatic venous flow pattern and other things, there are compilations, but then something similar not only happens in the systemic veins, but it also happens in pulmonary veins. What happens in pulmonary venous flow normally is also, here also, the pulmonary venous flow is systolic flow is more, both in inspiration as well as expiration normally. But in constrictive pericarditis, in inspiration it is normal, but in expiration, the flow becomes mostly diastolic. That is very typical of constrictive pericarditis. Inspiration, normal pattern. Expiration is abnormal. But in cardiomyopathy, diastolic flow is more both during inspiration as well as expiration. That is very typical of a restrictive cardiomyopathy. Now, do all patients having increased velocities of the flow across the mitral valve is synonymous with constrictive pericarditis? The answer is no. That the commonest cause of increased flow is obstructive airway disease. Okay, we'll come back to that later. But do all patients with constrictive pericarditis show this respirophasic abnormality? In the what you call Mayo Clinic series, almost about 10% of the patients did not show this respiratory pattern. And they attribute this to two reasons. One is there is a marked increase in the preload. That means the venous pressure is so high that it will not be able to demonstrate the variations in the flow, variations in the flow velocities because it's very high. But the second reason is that those patients with constrictive pericarditis, they not only have abnormality of the pericardium, but they also have abnormality of the myocardium. So basically, it is that kind of abnormality you should suspect. But the second reason that markedly increased respiratory changes in the mitral flow not only occurs with constrictive pericarditis, but also in patients with obstructive airway disease. You can also get pulsus paradoxus in these patients, not only in constriction, but also in obstructive airway disease. So how do we differentiate an obstructive airway disease with pulmonary compared to constriction? Probably one of the simplest ways is to analyze the flow velocities in the superior vena cava using a suprasternal, imaging. If you image the suprasternally, and then you can see the superior vena cava and you can interrogate the superior vena cava blood flow velocities. In case of constrictive pericarditis, there is no increase in the velocity of the flow in the SVC because during inspiration, there is that the pressure in the right atrium is not falling, but then the pressure in the extra pericardial SVC is falling because it is exposed to negative intrathoracic pressure. So if you find that the SVC flow velocities are increasing, then it is unlikely to be a constrictive, more likely to be an associated obstructive airway disease. Probably one of the most reliable method of diagnosis of constrictive pericarditis in 2020 is usage of tissue Doppler in trying to analyze whether the problem lies in relaxation or problem lies in pericardial constriction. Normally, you will find that the tissue Doppler shows an early diastolic wave, what we call E prime, and then a late diastolic wave, what we call A prime. Though E prime represents the relaxation, that the normal the reaction, that the relaxation, the steeper will be the E wave amplitude. And the slower the relaxation, the E wave amplitude will be far less. So in patient with what we call restrictive cardiomyopathy, here it is in the second form. First one is normal, second one is a restriction, third one is the constrictive pericarditis. You will find that in restrictive cardiomyopathy, the E wave velocity is markedly reduced, whereas in constrictive pericarditis, the E wave velocity is markedly increased, more than normal. Usually it is not less than 9 to 10 centimeters per second. The exceptions are there, but we'll come back to that exceptions later. So if you find that a prominent E prime by tissue Doppler, it rules out restrictive cardiomyopathy. It is more in favor of constrictive pericarditis. Normally, this E prime is more on the lateral side of the mitral annulus and less so in the medial annulus. But in constrictive pericarditis, the E wave prime is more exaggerated on the medial side and less on the lateral side. For example, if the medial annular velocity E prime is about 12 centimeters per second, the E prime on the lateral side will be only about 9 or 10 centimeters per second. This is what we call reverse of the normal, or what we call annulus reversus. This is supposed to be very typical for constrictive pericarditis, and it does not occur with restrictive cardiomyopathy. Again, there are some exceptions, and the classical exception to this one is what we call, whenever there is what we call mitral annular calcification, MAC, which is common in elderly females. So there is annulus inversus, annulus paradoxus. So from the what we call algorithm for diagnosis of differential diagnosis of constrictive pericarditis from restrictive cardiomyopathy is, so first you see the tissue Doppler interrogation of the mitral annulus at the lateral annulus and at the medial annulus. If the E prime is more than 6 centimeters per second, especially if it is more than 8 centimeters per second, it is totally against the diagnosis of restrictive cardiomyopathy, and it is definitely constrictive pericarditis, and no other tests need to be performed if the rest of the clinical picture fits with constrictive pericarditis. But if the E prime velocity is between 6 centimeters and 8 centimeters per second, then it can still be a restrictive cardiomyopathy or a constrictive pericarditis. So in which case, you evaluate the systolic function by evaluating the S prime of the tissue Doppler. If the S prime is markedly decreased, that means less than 6 centimeters per second, again, it is against the diagnosis of constriction and more likely to be a restrictive cardiomyopathy. So these are all the what we call the guidelines by which you can make a diagnosis of constrictive pericarditis at the bed without subjecting the patient for cardiac catheterization. So in summary, in constrictive pericarditis is characterized by dissociation of, that is thickening of the pericardium and the fibrotic pericardium, that causes a dissociation of intrathoracic pressure from the intrapericardial chambers. The second thing is it also causes exaggerated ventricular interaction. Important to use echocardiogram as the first line of investigations, and in difficult patients you can use MRI and CT for thickness of the pericardium, for inflammation of the pericardium, and for late gadolinium enhancement of the myocardium using MRI. And in very difficult patients, you can use cardiac cath. As I said, in Mayo Clinic, they use it cardiac cath for diagnosis of constriction only in about 25 to 30% of the patients, where the echo data is inconclusive, or the patients are in atrial fibrillation, wherein the changing cycle length makes the diagnosis and interpretation of the echo parameters very difficult. So finally, we will come to an algorithm wherein we say, in making a diagnosis, you should take a patient history first. If the patient gives history of radiation, history of connective tissue disorder, or history of pericarditis due to pyogenic infection spreading from the adjacent lungs, probably more likely to be a constrictive pericarditis. If there is a family history of cardiomyopathy, probably restrictive cardiomyopathy is more likely. Same way, physical examination, jugular venous pressure, and the pattern of steep X and Y in constrictive pericarditis, only steep Y and blunted X in restrictive cardiomyopathy. And ECG and X-ray, unless it is calcification, not very helpful. But I think advanced cardiac imaging by way of thickened pericardium, either by MRI or CT or even by chest X-ray. And in the difficult patients, you should use a tissue Doppler imaging of the mitral annulus and what do you call systolic function of the left ventricle using tissue Doppler. Thank you, ladies and gentlemen, for your attention. I'll take any questions if there are any. Thank you.
Thank you so much for an excellent lecture, sir. It was a great learning, fantastic lecture, fantastic talk, explaining all the hemodynamic principles and everything. So over to our panelist, Dr. Ankit Bansal, Dr. Sanjeev, and my colleague, Professor Girish MP. If there are any questions or comments that we have come across, you can definitely ask. Otherwise, it was such a clarified and a beautiful talk.
Thank you very much, sir, for this excellent lecture and very simple and systematic approach towards this diagnostic challenge. There are some questions in the chat box. Can we take these questions one by one?
Sure.
So the first is a very interesting question, although a rare scenario. How can we clinically differentiate between mitral stenosis and localized constriction of AV groove?
Good. I think basically mitral, you're trying to say between mitral stenosis and mitral annular calcification diagnosis,
sir,
right?
No, sir. How commonly do you see the regurgitation in constrictive pericarditis, and what is it?
No. As I said, clinically you do not see AV valve regurgitation. Tricuspid valve regurgitation has been reported, but it is more by echocardiography that you hear that you diagnose AV valve regurgitation. Clinical mitral regurgitation, clinical tricuspid regurgitation is extremely rare. As a matter of fact, if they are audible, you have to think more in terms of restrictive cardiomyopathy rather than constrictive pericarditis. Having said that, localized constriction at the AV valve, AV ring has been reported, and that has caused stenosis rather than regurgitation.
Okay.
Did I answer that question?
Yeah, did. Perfect. Thank you.
No, actually the question was, sir, it's a sort of tricky one. He says that if there is a localized constriction involving only the AV group, can it mimic mitral stenosis? That is the question.
No. Clinically maybe, but if you do a two-dimensional echo, mitral annular calcification, that the leaflets and the commissures are totally free. Whereas in mitral stenosis, the classical hallmark are the commissural fusion, thickening of the leaflets and doming of the leaflets. So clinically, MS is a possibility theoretically, but I have not seen a patient of constrictive pericarditis presenting as MS.
Okay, sir. Coming to the second question.
Yeah.
Why pulsus paradoxus is more common in cardiac tamponade and Kussmaul sign is more common in constrictive pericarditis?
No, even Kussmaul sign is also more common in what do you call tamponade.
Tamponade.
Actually, yeah, Ralph Shabate has shown that if you can prevent increase in the right ventricular input, if you can prevent it, then pulsus paradoxus won't occur. As a matter of fact, even in what you call P.S. Reddy's series of cardiac tamponade and constrictive pericarditis, according to him, he has never seen a case of a what do you call this rise in jugular venous pressure during inspiration in any of the patients of his constrictive pericarditis. That's probably an exaggeration, but in his series, none of the patients had any elevation of venous pressure during inspiration. But by and large, the answer is that the changes in the left ventricular volume in patients with constrictive pericarditis is much less as compared to changes in the left ventricular volume because of cardiac tamponade. So the pulsus paradoxus is only exaggeration of normal. A steep fall in the left ventricular stroke volume certainly causes a exaggerated fall in the stroke volume and consequently the systolic blood pressure. So the impact on the left ventricular filling in tamponade is much worse as compared to what happens in constrictive pericarditis.
Sir, one interesting question is regarding the systolic area index.
Yeah.
Is there any equivalent of that in echo?
Yeah, that's what I showed. No? That's what I showed you, that in the M-mode echo during inspiration, there is an increase in the right ventricular outflow tract area dimension, and then the left ventricular cavity dimension decreases and the right ventricular outflow tract dimension increases. This is the same thing what happens. This is area and that is pressure.
Pressure, okay.
So one more question.
Yeah.
So which is the most sensitive test for the pericardial thickness? We should go for CT or we should go for MRI?
Okay. Actually, in the setting of a minimal pericardial effusion, which sometimes it is there, CT cannot differentiate it unless you give the contrast. Whereas in MRI, it is easier to make out the pericardial thickness. There are no false positives.
Definitely, sir.
So if given a choice, MRI should be the choice, right, sir?
Yeah, MRI should be the choice, but
choice.
then MRI is not freely available. More than availability, interpretation by the experts is also limited. And probably there are some situations wherein the MRI may not be possible in a given individual patient because of other implants being there. But by and large, what we see here is CT is very good if there is calcification. CT. MRI cannot pick up what you call calcification.
So although you have already explained the role of NT-proBNP, please just kindly explain us again how frequently we should do NT-proBNP in these patients and what is the exact role in differentiating these two pathologies.
Yeah. In patients with restrictive cardiomyopathy, the walls of the ventricles are stretched. Okay. Whereas in cases of constrictive pericarditis, the walls of the ventricles are not stretched. As a matter of fact, they are prevented from expansion. So because the wall is stretched, there is release of NT-proBNP in restrictive cardiomyopathy, and there is no stretch of the wall in the constrictive pericarditis. That's why there is no release of NT-proBNP. In short, if the NT-proBNP is elevated during a diagnostic evaluation, you need to think that the patient has got a restrictive cardiomyopathy rather than a constrictive pericarditis. assuming that there is no chronic kidney disease.
One more interesting.
NT-proBNP cannot be used for monitoring the impact.
One more interesting question which has come around is the classical teaching says that there is wide and variable split of second heart sound in patients with CCP. This is described to be because of early A2. So what may be the pathophysiology of this?
No. Actually, there's an important point. It's not a wide and variable split. There is actually, this is the auscultatory equivalent of exaggerated ventricular interaction. I'll tell you. Normally, when you inspire, it takes about 3 cardiac cycles for the splitting of the second heart sound to manifest. Whereas in constrictive pericarditis, the split of the second heart sound occurs within the first cardiac cycle of inspiration. This is basically because of exaggerated ventricular interaction. It is not widely split. It is the timing of the split. Normally, when you inspire, it takes 3 cycles for the split to be manifest. But in patients with constrictive pericarditis, the split occurs within the first cycle. Abrupt splitting of the second heart sound with the onset of inspiration is one of the signs that have been described very long ago, and that is a sign of an exaggerated ventricular interaction. There is an abrupt decrease in the what we call left ventricular stroke volume. So there is what you call A2 occurs earlier and P2 occurs normally. But this abrupt precipitation of the split is more typical of a constriction rather than wide split. Anything else?
Thank you so much, sir. Thank you so much for taking out time to give an excellent talk. And it was such a pleasure for all of us to hear you. And we would request you sometime later that you can join us again and teach. And we have more than 550, 600 people live here. Thank you.
Sure.
And thank you all the panelists, Dr. Girish, Dr. Sanjeev, Dr. Ankit. Thank you, Intas, for supporting us. And thank you all. And this brings us to the end of the 6th webinar. And my dear friends, next week we'll be again coming with another, and that will be on X-rays, chest X-rays in cardiology, because this is one of the very commonly asked things. And Dr. Sanjeev Sharma from All India Institute of Medical Sciences would be joining us and taking us through that journey. So thanks again. Thank you, everyone. And till we meet next time, thank you. Goodbye.
Bye.
Thank you.
Thank you.
Thank you.
Thank you.